Hi, and welcome to Hope with Answers. I'm a patient activist, Janet Freeman Daily, who has lung cancer, and I'm here with Dr. Christine Lovely.
Hi, Janet. Please call me Christine.
Oh, thank you. I appreciate that. So, Christine, some patients like me have been on targeted therapies or TKIs for a really long time, but sometimes they stop working. Why is that?
Yeah, so this is a great question. So I think, when we think about these targeted therapies, these TKIs, they can work like gangbusters. And in your case, they did. And for a long time, that's amazing. But we're still not doing a good enough job, because what can happen is the tumor finds a way to get around the drug. So let me give you an analogy. Let's say you're going from your house to your grocery store, and your usual route is blocked. You have to find a way to get around that blockade. What the tumor does is something very similar. So the tumor likes to signal through a particular oncogene, which we've talked about in other discussions. And what happens is the drug blocks that oncogene, but the tumor is smart and it finds a way to get around the drug. So it finds that alternate route to get to the same effect, which is growing and not behaving the way that it's supposed to, not listening to the normal signals that our body is supposed to give ourselves.
The cancer kind of evolves.
Exactly.
Okay, so I've heard the term acquired resistance. Can you tell me more about that?
Sure. So acquired resistance means that tumors respond beautifully to these TKIs. So meaning the tumor is there, the patient starts taking the drug, the tumor goes away. What happens and what can happen and what we're all trying to fight against is that the tumor can learn to get around the effects of the drug. This is what acquired resistance means. It means that the drug worked really well, but then all of a sudden it stops working. So we, as patient advocates, as doctors, as healthcare providers, everyone, we need to figure out a way. How do we stop the tumor from getting around the drug? How do we make it so that the tumor still responds?
So I'm going to get a little technical here. I've heard there's more than one kind of acquired resistance.
Yeah.
So sometimes there's actually a mutation or a change in the DNA that keeps the drug from binding to the protein. And then there's another kind. What's that?
Sure. So I think about it this way. There's two ways that tumors can get around the drugs that we give them. The first one is, like you mentioned, how do you actually change the drug target? So one of them is by mutating the drug target. And that's a word that can mean a lot of different things to a lot of different people, but I like to think about it this way. Let's say that my hand is the drug, or my hand is the tumor, and my other hand is the drug.
And something comes in and blocks that.
And we just change the tumor just a little bit, like this. Now the drug and the tumor are not interacting the same way anymore.
So it's not connecting. Okay.
It's not connecting. And so the tumor changes, it mutates, so that the drug doesn't work, doesn't bind the way it used to. That's one way that tumors can become resistant to these targeted therapies or TKIs.
But then something else can change in the cell that makes the drug stop working because the cell figures out how to get around that.
Exactly.
Okay.
And so you can have changes in the tumor itself, in the target of the drug, but you can also have these alternative routes, like we talked about before, that tumors develop, so that they say, well, the drug is present, but I don't care. I'm going to find a way to get to the same endpoint, which is to grow and not listen to the normal checks and balances and proliferate in a way that even though the drug is present, I'm going to work around the drug.
Okay, so say this happens. I've developed acquired resistance. Do I need another biomarker test?
For most of the tumors that we think about in lung cancer right now that are treated with targeted therapies, I would strongly encourage any patient to talk to their doctor about getting another biopsy, about looking at the tumor, because what we really need to understand is how the tumor changes over time. Why did the drug all of a sudden stop working? And there are additional biomarkers that we can look for that we can even potentially target with another TKI to overcome the drug resistance.
So, and I understand that for some types of targeted therapies, you can actually have a liquid biopsy to determine what your acquired resistance is?
Yes, and so this is something where our science and the way that we think about treating patients in the clinic and the tools that we have really exploded in the past few years. So
I didn't define liquid biopsy. Can you do that?
Sure, absolutely. So liquid biopsy is actually a way where instead of taking a piece of the tumor, so you've had biopsies where they have to go in and they go through your lung and they take a piece of the tumor out. Mm-hmm. A liquid biopsy is actually where they take your blood, just a normal blood test, take the blood out, and they can actually find fragments of the tumor DNA floating around in the blood, which is if you think about it,
that's pretty amazing.
It's amazing.
It is.
And so because we have such sophisticated technology right now, and we're really learning all together how to use the technology in a good way in the tumor and in the clinic, we can actually take that blood, find the tumor DNA, and sequence that tumor DNA to look for these mutations that mediate resistance.
Okay. So I have acquired resistance. What happens next? Do I get to take another TKI? Do I have to go on chemo? Am I out of options? Do I do a clinical trial? What do I do?
Yeah, so I think for when acquired resistance happens, this is going to be something where a patient wants to really talk to their doctor very closely to figure out what is the next step. And it can be very different depending on what marker is in your tumor. So there are different drugs for EGFR than there are for ALK, than there are for ROS1, and the resistance mechanisms are a little bit different. And so this is a case where there are lots of examples where if a tumor does become resistant, then we can treat it with another TKI that would be based on additional biomarker testing. So we want to make sure that we're bringing the precision to our next line of treatment. But the actual drug that comes next is going to depend on what the initial target was and then what the mechanism of resistance is. Now,
some patients are at hospitals where they might not have never seen a patient with ROS1, that's rare, and their doctor may not know what to do next. What can a patient do at that point? Are there some expert doctors their doctor could consult?
Sure, yes. I mean, I think that the lung cancer community is a really close and tight one, and I think we all share the same goal of trying to deliver information and the best therapies to all of our patients. There are lots of wonderful organizations like the Ross Wonders, like the Alchemy Organization, like the International Association for the Study of Lung Cancer, where there are communities of oncologists like myself who are ready, willing, and able to help patients and other doctors anytime that it's needed.
That would be great. So another little detail. Sometimes patients are on TKIs for a long time and life is somewhat normal. Last year, I had foot surgery and I had to stop my TKI for a while. Are there situations where you have a patient stop a TKI for a while?
Yes. So I think stopping the TKI for a while, what we want is for everyone's life on these drugs to be as very normal as possible. And life happens, and sometimes you need a foot surgery, or sometimes patients are going on vacation and they don't want to take their drug, or sometimes there's, God forbid that somebody's in a car accident and they need to have a surgery to repair a broken arm. There are lots of circumstances where sometimes you'd have to stop the TKI, but then restart it afterwards when that acute situation is resolved.
Christine, sometimes I've heard that patients will be off a drug for a period of time and they might experience a flare in their disease, a TKI flare. Can you tell me about that?
Sure. So TKI flare is a little bit different than when we were just talking about going off the drug temporarily. So let's talk about two scenarios. Going off the drug temporarily, like if you have a surgery or some acute problem, and then the flare. So what we know about flare is predominantly from the EGFR literature, where patients who have deep and beautiful long responses to EGFR inhibitors, when their tumor becomes resistant, the patient will stop taking the drug, and usually about 7 to 10 days afterwards, we see what we call flare, which means that the tumor actually starts growing more. Now, I don't want to panic anybody or sound alarming. This is not something that is very well characterized. There's a few papers on it.
It's not everybody.
It's not everybody.
Oh, okay.
It's not everybody. We don't know who's going to get it, who's not. Most of the information we have about flare comes from EGFR mutant tumors, so we don't have as much information about flare in ROS1 or ALK or some of the other mutations we think about in lung cancer. Now, that's very different than if I have to go off TKI for a few days for a surgery, or because I'm traveling somewhere, or because I have some immediate acute need that has to happen. I think we as doctors are very comfortable with stopping the TKI for a couple days, knowing that it's going to go back on. That's very different from the flare situation.
So I think perhaps coming off the drug is one case where it would be very helpful for doctors who might not be familiar with the particular drug to consult an expert to find out if they've had other patients that go off the drug.
Absolutely,
yeah.
Yes. I think one of the beautiful things about our lung cancer community is the fact that everyone works together so well, and this is patients and doctors all over the country, and I think we all just really share the same goals. We want to help people as much as we can.
Okay. Thank you very much for your time, and thank you for joining us on Hope with Answers.